Good morning, everyone. Thank you for joining us for your day 2, track 1. So we are going to be hearing from Dr. Prithvi Mruthyunjaya. He's an associate professor of ophthalmology, and he is pretty pretty impressive. He's the director of oncology service at the Byers Eye Institute at Stanford University, and he is a vitreoretinal surgeon who is focused in his clinical and academic career to the care of patients with eye cancer. And so he is a repeat offender for I Believe Survivorship seminar, and we're so happy to have him. Welcome, Dr. Prithvi Mruthyunjaya.
Thanks, Bree, and thanks, Melody, and thanks to all the organizers. I hope everyone can hear me okay. Really an honor to be part of this session, and I really wish that we could all have been together and meet together. I had the opportunity to um, present some data on ocular melanoma at one of our national society meetings last week. It was like very safe, and everyone was vaccinated and were wearing masks. But it was such a difference to be able to see folks in person. So I really hope everyone's safe, everyone's been well, and we can all do this together in person. So let's get started. If my slides can come up, please. So I have the daunting task today of this honor of this keynote address. I think that's actually just way too formal for someone like me, mainly because I look at this opportunity to chat with this group as really it's a pleasure and it's an honor to be able to do so. I want to say hi to all of my patients and acquaintances and their families who have signed in this morning, maybe even some of my friends from the East Coast, but also the West Coast friends who have woken up so early to join this morning. And this is just a wonderful opportunity. So I'm going to talk this morning about what's new in uveal melanoma in 2021. And this is a really interesting and special year the for our field. And the reason is that there has been some groundbreaking new data that's been released by all the scientists and the corporations that are working towards making this a reality to help our patients. So I'm going to give a lot of technical information. The nice thing is that we have other experts who are speaking today that are going to continue to re-explain the same information. So by the time you get to their lectures, you would have heard it at least once, and let them allow us to give us their technical expertise as we add to our collective knowledge on this. So if we can go to the next slide, please. So here are my disclosures. Next slide. So I do want to hark back to some of the really good memories we've had working with Acure Insight. These are some images from the last uh, uh, Run for Cure that we did at Stanford University, which has now been almost 2 years ago. And we really hope in 2022 we can get everyone together. Here's some of the images of our staff and our teams and our doctors and our patients. Next slide, please. And most importantly, next slide, a special shout out to my very close friend who has helped support our patients on and my patients on two coasts now, on the east and the west, and really a ball of energy and positivity and hope. So thank you for all you do. Next slide. So we know that cancer is a global problem. We know that the number of new cases, if we divide them between adults and both men and women, represent just an astronomical number. The number of new cases of certain types of cancers outpace the population of some countries. So it's really amazing what a burden this is on not only patients but families as well. Can we go to the next? But one of the things that is clear is that there is important trends that are being made that are very positive. So if we look here now at the war against cancer and survival of patients, what we're seeing is that the number of patients that are succumbing to their cancers are changing, and this is what we call the war against cancer. Next slide. So what we're finding is that the trends to patients that are succumbing to their cancers keep going down. Next slide. And I think that it's a combination of science that makes this happen. So I think that we are winning, and this is because there is awareness, there is prevention strategies, there are screening strategies, there's super science that's coming to the forefront, and there are amazing therapies that are being made available to our patients. Next. So what we're going to talk about are really melanomas and molecules and where we are in 2021. Next slide, please. We're going to talk about the standards of care currently. We'll talk about emerging therapies and specifically how this impacts patients that may develop metastatic disease. Next slide. So let's just run through quickly the current state of care in uveal melanoma in 2021. So first, next slide. We make our diagnosis of ocular melanoma in the clinic. We don't have to take a biopsy. Next slide. That confirms diagnosis in all cases. We can use very powerful imaging modalities, and that's when, if you come to the clinic and you get pictures taken and many, many pictures and ultrasounds, all of that kind of comes together in a model that allows us to make accurate diagnoses and help to monitor disease as we go forward. So our imaging technologies are only getting better, much more sophisticated. And now we're employing techniques using artificial intelligence, which may be another way that we can improve on how to better diagnose these conditions. Next. When we diagnose uveal melanoma, we have clinical features that help us to determine whether we are concerned about a lesion that may try to grow. We know that sometimes patients will have a lesion. We'll call it a nevus or a suspicious nevus or an indeterminate lesion that may have some of these risk factors, and they may grow a little bit, but it's the rate of growth, the severity of some of these risk factors that really push us towards treating patients earlier and earlier these days. Next. It's important that we can estimate the risk for a patient to develop what we all fear, which is metastatic disease. In the past, we would just use clinical features. Next. Or in some cases, when eyes were removed, we would look at it under the microscope and then determine what the metastatic risk might be. Next. But now we have much more powerful molecular tools. So we can look at chromosomal alterations, even through a small biopsy that's taken of the tumor, that tells us whether patients will have higher or lower risk features. Next. And now we're all aware of the role of gene expression profiling. Next. That gives us this information in much more greater accuracy. This is the outputs from the Castle Biosciences outputs for defining class 1 and class 2, and we're also aware of PRAME as another marker for potential risk for metastasis. Next. We know that we have great treatments for local control of the melanoma in the eye. If we remove the eye, which is enucleation, we have essentially a 100% chance of local tumor control. Next. Or we can also employ radiation therapy next that has a very high rate of success, probably higher than 94 to 95%, either given as proton beam therapy or next, what we call plaque brachytherapy, where the radiation source is placed on the outside of the eye. So we do a very good job in treating the tumors within the eye themselves. Next. But a study that we published in JAMA Ophthalmology in 2020 shows that now over the course of a 10-year period more recently, we're seeing a marked uptick in the use of radiation therapy, up by 14%, and a 10% decline in the use of enucleation. So again, I think we're catching tumors earlier. We're understanding the scope of where radiation therapy can come in. So in this process, I think we're able to now preserve more eyes when it's safe and when it's appropriate. Next. Some of the other advances that I think make the current standard of care the best it can be, next please, is the use of precision radiation planning. So we use a combination now in many cases of not only images from the clinic, the clinical data that I provide as the physician, but also the uses of MRI technology that helps us to bring all of this information together. We use advanced techniques to obtain biopsies of tumors in eyes that we're doing radiation therapy on, or in even eyes that we remove. And these techniques are providing excellent results for us and good ability to provide prognostic information. Next. And finally, another area that we'll hear more of in the years to come is active management of patients that develop radiation side effects or radiation retinopathy, with the goal to either stop it, delay it, or prevent it altogether. So we'll be hearing more about that in the years to come, as more trials are now going to be open for that. Next. We know that it's important for routine metastatic screening because, unfortunately, far too many of our patients may still develop metastatic disease. There are different ways to screen for this, including CT scans, MRIs, PET scans, and ultrasounds. We find that using blood tests or liver function tests, which were very popular in the past, probably don't serve as much utility as we thought they would. So we go with structural screening of body organs. Next. One of the important advances, I think, in the legitimacy of uveal melanoma amongst all the other cancers out there is the NCCN, the National Comprehensive Cancer Network, which is a compilation of experts in the field of oncology, radiation, epidemiology that have all come together to make guidelines that insurance companies and other physicians use to make treatment decisions. And the most important was that uveal melanoma now is one of the main cancers that have been pushing the these types of guidelines forward. We have to thank several of our colleagues who have helped us to advocate, most specifically Dr. Miguel Matarin from Duke University, who is one of the ocular oncologists that represents us on this panel. Next, please. The important thing is we have now been able to define low, medium, and next high risk characteristics that then correlate to a recommendation on screening frequency. So how often should you be getting scans, or what other things you need to be doing? So this risk-based screening is helpful for patients because it provides them a foundation for what should be standard of care, but it also helps to advocate for our patients when insurance companies give us a hard time getting the necessary scans done. We kind of pull out the document, and I've had some very easier conversations with insurance companies when I'm fighting and advocating for my patients. Next, please. So let's go into the tough stuff here. This is the review of some of the more recent data that we're going to be talking about. And these are really experimental avenues in uveal melanoma, and we'll talk about improvement in non-radiation treatments for the eye and ways that we may have newer strategies and tools to treat or maybe even prevent metastatic disease. So let's go to the next slide, please. So let's first talk about improved non-radiation treatments for ocular melanoma. And the problem is that when we treat small melanomas, there is a risk of vision loss from radiation therapy. Next. Why do we need new treatments? Well, I told you that we are very effective in treating intraocular melanomas, but they often result in vision loss for our patients. Next. Because when we're treating the melanoma next, we're not just treating the exact tumor itself. We have to be aware that there is next a change in the tumor, but also the radiation impacts next a zone around the tumor, and that zone may encompass critical vision structures, including the optic nerve, which is shown by the arrow, and the center of the vision called the fovea. So even though we're very good at treating that tumor, there can be collateral damage to normal tissues. Next. We know that radiation retinopathy is slowly progressive too. So the vision loss is not usually immediate. And we know that patients can develop, nearly 40% will develop some form of structural change in the retina by 4 to 5 years. Next. And vision changes can also occur. So about 50% of patients may lose the ability to see several lines on the eye chart, which is thought to be significant, by 3 years after their treatment. So we do know that patients can have successful treatment of their tumors, but vision loss becomes an issue. Next. So here comes a new treatment. So this is by a company called Aura Biosciences. They're a innovative immunotherapy company that's that's based out of research that came from the National Institutes of Health. And what they've done is they've created a virus-like particle. Now, whenever we hear the word virus these days, it gets really, we get really nervous by this. But this is not a SARS-CoV-2 virus. This is a virus-like particle. So what it is they've taken the human papilloma virus, which is a very common virus that can cause various conditions in the eye, but we're almost all exposed to it to some way or another. So we've learned a lot about this virus. We take away the bad part of the virus, the things that will infect and cause trouble with spreading or reproducing in the wrong way. So it's just a shell. And then we add to it a cytotoxic drug, which is basically the target, and then we put it all together. This is the first in cancer type of molecule that has done this and is in clinical trial. Next, please. What the schematic shows is when you have this virus-like drug conjugate, or VDC, and you put it into an eye with a melanoma or into the eye, what happens is that it has an attraction to specifically the melanoma cells. And there are features on the surface of the cell that it only attaches to, but it doesn't attach to healthy or normal cells. So if you inject many of these particles into the eye, they will coat the surface of the melanoma. And it's engineered in a way where one arm attaches to the tumor and the other arm has basically a smart bomb attached to it that we can activate with a very specific light source. So we don't have to burn it or radiate it. It's just by a special light that then activates that smart bomb, and it allows the cell to then be destroyed by the own immune system. So it's selective tumor targeting and selective death. Next, please. I think of this as like a drone delivering a package. So the drone is just the vehicle, that's that viral-like particle. The package is what's going to actually kill the tumor cell, and we want it to go to a specific location, which is directly in the eye. So think of this Aura product as a highly specific engineered drone that's bringing a package to kill the melanoma. Next. So here's some of the mechanisms of action. So we have this viral-like particle. It's entered into the eye and it can be injected into the eye itself. A special light is added to the eye through a laser source. So it's just directed right through your pupil. And two things happen. One is that when this light activates the molecule, it directly bursts cells. So it kills the tumor cell that it's attached to. But more importantly, it then starts to upregulate your own immune system. It tells the immune system, this is what you need to go after, and go and get it. And it then brings our own T cells, which are the cells that destroy abnormal things in our body. It tells the T cells to come to this specific location, which is the melanoma, and then the T cells destroy it. So it's a two-action way of destroying the tumor cells. And it doesn't matter with this treatment whether you're class 1, class 2. We don't think that it makes a difference on the genetics of your specific melanoma because it's going after a non-genetic mechanism to treat the melanoma. Next, please. So this has now been in early phase clinical trials. So these are patients that have been treated with this product. They often get, at least in the last clinical trial, a series of injections each week for 3 weeks with the laser treatment done right after the injection is given. And that can be repeated 2 times. So 3 weeks with the laser and injection, wait a little bit, do it again for 3 weeks. So it's all done in the clinic. There's no operating rooms involved. And right now it's still under clinical trial. What the graph on the left shows us is that patients that had this medication and treatment were able to maintain visual acuity in a most unexpected and fantastic manner. So these are patients that we would have expected with radiation treatment to have poor visual acuity after 12 to 14 to 24 months. And now many of them, about 91% of them, were able to preserve their vision at these short outcomes. So that's actually very encouraging for a treatment. Next, please. But the real question is it working? So if you take a look at these, at the graphs on the left, the larger teal graphs are the rate of growth of the tumors that were entered in the study before treatment. So these were eyes that had melanomas that were small, but they were growing. After the treatment is the small blue graph that shows that the rate of growth after the treatment was significantly reduced. So there was an incredible ability of this treatment to either halt the growth, make it go smaller, or at worst, taken together, allow the melanoma to have been slowed down significantly. And this is really, very interesting data. Let's go to the next slide. What we have now are different ways that this medication is being tested. So one is by injecting the medicine directly into the eye, called an intravitreal approach, and this has already completed its initial phase 1 study. Next slide. Or the second option, which is now in a current phase 2 study that is currently ongoing, is delivering the medication instead of into the eyeball, where it then goes and hits the tumor from the inside, kind of going back around the eyeball. So it's called suprachoroidal delivery, and it brings the medication closer to the melanoma, kind of from the outside of the eye. So what does the AU011, back one slide, please. What does the AU011 study mean for you from Aura Biosciences? Well, it's an experimental therapy with promise. So it's still early phase, phase 1 to phase 2, and then ultimately the plan is for a multi-nation phase 3 study, hopefully starting in 2022. What patients would be specifically targeted with this? Well, right now, new patients with small uveal melanomas. So if I've had a melanoma treated, we're probably not using this medication for it. And it may be an alternative to radiation therapy in certain patients, probably not very large tumors, maybe smaller tumors. And there's still much testing that still needs to be completed to know whether this is the real deal or not. But for the first time, we have a clinical trial in place to give us an alternative to eye removal and an alternative to radiation. It's being done in an ethical and very well planned manner, and many of the ocular oncologists that maybe even take care of you have been asked to chime in on their opinions. So it's really a collaborative community effort. So Aura Biosciences AU011 We'll look forward to more updates on that as the year comes forward. Next, please. So the next topic is preventing and treating metastatic disease. So the problem is that uveal melanoma, when it metastasizes or spreads to other parts of the body, still has no proven approved treatment. And that's a big problem. We know that micrometastases occur before even the eye disease may have been diagnosed. That's why I tell my patients that even though we're going to start treatment, say radiation treatment or eye removal today, the goal of this is to prevent any future spread of those cells from the eye to the rest of the body. But it can't change what we've done or what may have happened yesterday, last month, or even last year, whether one cell or two cells may have left the eye and are floating around in the blood. So I think that's the challenge here as we're looking through is how do we intervene at various time points to be able to stop this process from occurring? And if it does occur, how can we treat it best? Next. So we talk about adjuvant therapy next, and then active therapy for the liver lesions specifically. Next. So a couple of trials that some of you may have actually been involved in. This is an adjuvant trial, which means to give the medication before patients are known to have developed metastatic disease. This is a medicine called Sunitinib or Sutent. Dr. Dr. Sato from Jefferson Medical has been the leader in this trial. So it's a tyrosine kinase inhibitor, which is known to have anti-melanoma activity. It's been given to patients that are thought to be high risk. These are patients that have unfavorable tumor genetics or large tumors at presentation. Patients have been using up to 6 months of this treatment, and it's taken as an oral pill, which is very nice, and it seems to be reasonably well tolerated. When compared to historical controls, there was a significant improvement in survival in patients that were given this medication, particularly younger patients. So more long-term data is needed, and a more robust control population may give us more information about this. But this is one strategy that's been used in patients with high-risk uveal melanoma. Next. There are what we call off-the-shelf directed therapies. We know that there are a whole host of medications that have been approved for metastatic cutaneous or skin melanoma. Now, we know that skin melanoma is not the same as ocular melanoma. They have the same last name, but they're distant cousins. They behave differently. But there are enough similarities that physicians have been using some of these checkpoint inhibitors as well as kinase inhibitors to try to address metastatic melanoma. And a recent study coming out of MD Anderson looking at ipilimumab and nivolumab did show a more promising response in these patients, up to 18 to 20% of patients with response with these checkpoint inhibitors. So this is helpful, and it's something that many patients are started on as part of therapy that's available, but these are not specific to ocular melanoma, but they are available treatments that we can use right away off the shelf. Next. Next slide, please. Thanks. Back one. Thanks. Yes. So what we want to think about is newer ways to use immunotherapy. What that means is how do we harness our own immune system to attack the melanoma cancer? So what we want to try to do is can we ask about redirecting our own T cells, our own cells that are out to kill foreign invaders, to kill the cancer within our eye. In order to do that, we need to kind of flag our immune system and say, hey, come over here and direct the immune system to the cancer itself, and then use our own inherent abilities to attack foreign invaders in our body called T cells to attack the cancer. So you need to have something that identifies the cancer cells and also brings the abnormal cancer cells in light and contact with the T cells that are functioning in our body. Next. So this schematic kind of gives us a broad picture. And this was presented at the American Association for Cancer Research at one of the spotlight sessions earlier this year in 2021. What we know is that a lot of mechanisms to target cancer cells with the immune system, which include antibodies, CAR T cell therapies, and other proteins, count on markers that are sitting on the outside surface of the cell, so cell surface proteins. And if they can find one to attach onto, then they can call the immune system to come to it. Most of these proteins are not, however, on the surface of the cell. The bulk of the proteins are inside the cell. So you may have more options of how to really target the cancer cell if you can attach yourself to some of these proteins that are more abundant and more specific that are located inside the cell. And this is what this company called Immunocore has been able to do. Immunocore has created a new technology called ImmTAC, which basically is a molecule that is delivered into the body that on one side has a specific target that's located inside the melanoma cell. So it's looking for proteins that are inside the cell, which are more abundant but very specific. And it allows this molecule to attach to it. And on the other side, it calls the immune system to come in and attach itself to the molecule, and it brings everything together, the cancer cell and the immune therapy, the immune cells, and then it allows the cancer cells to get destroyed. Next. So another version of this, so it's used at first in uveal melanoma because of several key properties. One is that melanomas themselves have very few mutations within its genetic code. They have specific ones, but they don't keep making new mutations that have to keep confusing the immune system. So it's a consistent burden of mutations so that the treatment can attach itself to it more regularly and directly. What we've been able to find with this is that there's a very specific ability for this molecule, now called tebendifusp. So you'll hear that word again, tebendifusp, also called TEBI for short, to be able to go into the body, attach itself to the melanoma cell, but also attach itself to the T cells that are floating around and bring them together so the T cells attack the melanoma cell. Next. So I'm a simple guy. I'm going to just break it down to you. In our blood, we have the green melanoma cells that are floating around, and we have T cells that are floating around but may be not directing themselves to the melanoma in general. Next. But what we can do with this new molecule, so TEBI helps to bring these blocks together. It attaches itself to the melanoma cell and it brings the T cell right nearby. And when the T cell is attracted to the melanoma cell, the T cell can help destroy the melanoma cell. So what this molecule is doing is to bring order to the immune system so that it is directing itself specifically at the melanoma cell. Next. So this is called bispecific T cell redirection therapy. Now, if you can go to the next slide. Basically, we're injecting this medication into the body. It's attaching itself to specific targets within the melanoma cell. And this is where it gets very advanced in the science. There are specific markers within our cells and specifically within our bodies called HLA types. It's kind of like a blood group, but a little bit different, but something specific like a blood type. HLAs are divided into different groups, A's, B's, C's, and even within the A group, there are specific HLA types. And this HLA-0201 is a HLA connector that is seen in about 30 to 50% of the population. So this treatment only works if you're HLA-A0201 positive, which means not all of us will have this HLA type or this blood group type, if you will, in us. And only if you had this is this molecule built for that. This is the study that was presented at the AACR meeting earlier this year, which is a phase 3 randomized study of TEBI compared to doctors using whatever treatments they want in first line, which means as the first treatment in metastatic uveal melanoma. This was a major paper that was presented and a lot of highlights and spotlights. You can see some of our ocular melanoma medical oncologists were involved in this report. Dr. Shastari, Dr. Orloff, Dr. Carvajal, Dr. Hamid, and others. So we are grateful to their contributions. Next. So what this study took was 378 patients who were randomized. Back one, please. And the bulk of the population received TEBI, compared to 126 patients that were allowed to use whatever medications were available for them in this trial. And they followed these patients looking at safety and whether it was effective. Next. So these are the patients that all had disease. Most of them had disease in their liver, which was the most common source. And overall, patients tolerated this medication quite well. Next. This is the bottom line. So the primary endpoint was overall survival. If you were on the TEBI, which is the yellow, compared to if you're on the best available medicines as we are today, the curves separate, and that separation means that there was a significant survival benefit by using TEBI compared to if you didn't. Now, it doesn't mean that this cured everybody, but compared to what's available, patients that were eligible and could tolerate the treatment had a survival benefit. This is the first time in uveal melanoma history that there is a treatment that's gone through phase 3 studies compared to another treatment that was also being used that showed a benefit of this new treatment. This is landmark. This is something that is really very, very important. Next slide. So what the study concluded is that TEBI, or tebentafusp, showed a highly significant and clinically meaningful improvement in overall survival as a first-line treatment of metastatic uveal melanoma. It's the first investigational therapy to improve overall survival in metastatic melanoma in history. And it was a drug that was manageable for patients, and side effects were there, but actually better than expected. And there were no treatment-related severe side effects from the treatment itself, which is fantastic. Next. So is tebentafusp, is it for me? Well, it's again, it's selective. So it's only patients right now that have this HLA-0201 specific construct in their body. So the truth is not every patient who has metastatic disease would even qualify to get this treatment. So that's a tough one, right? Because if it's available but I can't use it, it still doesn't help me. Now, it doesn't mean that there wouldn't be other HLA types that they're trying to develop or other treatments that come forward. But this is an important step because it shows that we can harness specific tracking of markers within tumors and bring in the immune system. So that whole concept is really revolutionary and opens many, many more doors. It's likely going to be used in the metastatic setting, but there are trials to look at whether it can be used to prevent metastasis. So I think that's really important in the adjuvant setting. And it's still being looked at by the FDA, and we're awaiting approval. So next slide, and we'll summarize. So what we're talked about today was improved non-radiation treatments, the drone delivering the target with the Aura Bioscience study, and treating and preventing metastatic disease with new immunotherapies, which is the Legos all mixed up, that now this new medication called TEBI helps to organize those blocks so that the T cells are right next to the melanoma cells and can be used to destroy the melanoma cells. Next, what do we have to look forward to in uveal melanoma in 2022? I think a lot. So the first is we do await the FDA on their decision on tebentafusp. That will be an important breakthrough for our patients and our community. I'll also say this, there are many, many, many new medications in clinical trials now in uveal melanoma. It's like a dawn of a new era. People are now realizing that this is a very targetable cancer, and it really needs attention. I strongly recommend you all to sign up for Cure Insight's email messages and social media posts. They do a fantastic job of updating any new clinical trial information that comes up, and any early results. A lot of these are still in phase 1, phase 2, phase studies, so it's still a ways to go. And many of us are working quite closely with these companies that are coming up with these novel ideas. Not all of them are going to work, but the fact that there is such an interest for our patients in this disease, it's amazing. And I'll bet, just like in cutaneous melanoma, the number of options have increased significantly over the past 5 to 10 years. I think the next 5 to 10 years is going to be significant in uveal melanoma. We also look forward to data from the COOG-2 study that many of you have been involved in. Over 1,700 patients have been enrolled in the study looking at the role of PRAME as a marker for predicting metastatic disease. And this is likely going to have some early data rollouts in 2022. And coming up is a multi-center study on radiation retinopathy that is in the planning stages and very close to executing. Last slide is my thanks. Thank you for allowing me to present today and to be a part of so many journeys of our patients and their families. And I'm grateful. Thank you.